Oh, thank you very much, Dr. Pratap. It's a pleasure to see you always, and it's a pleasure to be invited for a conference from India, always. So my name is Sandeep Basavarajaiah. I'm a cardiologist in Birmingham, in United Kingdom. So in this presentation, I would like to give you our experience of Magic Touch sirolimus-coated balloon. So the objectives of this lecture is to go through the indication for DCB in coronary intervention, potential advantage of sirolimus or paclitaxel balloon, and some case-based example from our center. So the current data for DCB in angioplasty is for restenotic lesions and small vessel disease. And ISR, we have endorsement from the European Society of Cardiology guidelines. Whereas small vessels, there is no endorsement, but we have data to support use of DCB in small vessels. So in my practice, I use DCB as a first choice for all restenotic lesions. Diffuse small vessel disease, where I want to avoid putting a long layer of stent, which is a recipe for future restenosis, which is very difficult to treat, as we all know. Important side branch ostium, especially when you have a bifurcation lesion like a 001 Medina classification, where you want to only treat the ostium of the side branch. It's very difficult to do with a stent without having to compromise the main branch or missing the ostium. Finally, patient having issue with the DAPT, especially those awaiting a cancer surgery. So in these kind of patients, we can use DCB. So we have two kinds of drug-coated balloon in the practice. One is a paclitaxel-coated balloon, which has been around for more than 15 years in practice, whereas sirolimus-coated balloon has been around for the last 4 to 5 years. Now, what are the advantages of sirolimus or paclitaxel? So starting with the mode of action, sirolimus is a cytostatic drug, whereas paclitaxel is a cytotoxic drug. In regards to margin of safety, it is quite wide for sirolimus because it's got a wide therapeutic range, whereas paclitaxel is quite cytotoxic and has a very narrow therapeutic window. In addition, the sirolimus not only offers anti-restenotic property, but also offers anti-inflammatory properties. In fact, we all know now that we don't use any more paclitaxel stents, and the sirolimus is the drug of choice for all currently available stents. And this is based on solid clinical evidence. And in addition, we probably have seen this paper from Katsanos, which was published a few years ago, which raised a slightly alarming signal that there may be a risk of long-term increased death with paclitaxel-coated balloons in peripheral intervention, but this was not reflected in coronary intervention on subsequent studies. Now, despite having such a good advantage of sirolimus, there are some issues with sirolimus. One, obviously, is that the tissue absorption is quite slow as compared to paclitaxel because it is poorly lipophilic as compared to paclitaxel. And moreover, even if it is absorbed, the retention in the vessel wall is very, very short as compared to paclitaxel. So this makes it very challenging to design a sirolimus-coated balloon. But this has been achieved by Magic Touch, which is an Indian-based company, which have done a great job by encapsulating the sirolimus particles in a nano carrier, which is basically a phospholipid carrier. So it's highly lipophilic. So it gets into the vessel wall and then releases from the reservoir over time. So they have addressed both the absorption into the vessel wall and also slow release in the vessel wall. We embarked this technology in 2018, and so far we have used in over 650 patients. My current use of DCB as a whole in my practice is around 25 to 30%. Now, I'm not going to show the data in interest of time. I'll jump straight to the cases. So I'll start with the first case, a 65-year-old man with crescendo angina. He had an inducible ischemia in the LAD territory. The angiography demonstrated a diffuse disease in the LAD. As you can appreciate, there's a tight stenosis in the mid-segment, but the whole LAD was diffusely diseased. There was a ischemia in the LAD territory, so we had enough justification to treat this. So proximally, we used 2 overlapping drug-coating stents, and we didn't want to give him a full metal jacket, so we used a POBA first in the distal segment. And after POBA, we felt there was no significant flow-limiting dissection, although there is a little bit of dissection here, but the TIMI3 flow was there, and there was no significant recall. So we decided to use a 2 overlapping DCBs, which are Magic Touch. And we had a final result like this, which looks acceptable with no obvious dissection. Patient came back for a follow-up at 6 months, and you could see that the LAD treated distally with a magic touch continued to look good. Maybe a small recoil in the mid segment, but on the whole, it looked better, and patient was asymptomatic. And if you compare the final result to the one at follow-up, you'll see the positive remodeling of the vessel, and we see this often with the DCB, where the vessel positively remodels, although it may not look great initially post-procedure. The second case is even more interesting. This is an Asian gentleman who presented with angina, diabetic, hypertension, ex-smoker. He had an inducible ischemia in the RCA territory. And the angiography basically showed he had a stent in the LAD in the past, which was patent, but the culprit this time was the RCA, which was subtotal occluded in the PDA, and there was a tight stenosis in the distal RCA. So we went on to treat this. The plan was to treat the distal RCA with a stent, and this with a proba and maybe a DCB. So after crossing with the help of Corsair and a Fielder FC wire, we implanted a short regulating stent here in the distal RCA just before the crux, and we had a result like this. And then we did the balloon dilatation with just a 2 millimeter in the PDA, and this was the post-proba result. As you can see, the vessel is too small to put a stent, and obviously, even if you put a stent in, you have to put a very long segment of stenting. So we used a 2.25 or 40 millimeter magic touch here, and we had a result like this. This is post DCB, and we accepted this. And patient came back a year later with some atypical chest pain. So we did the angiogram, and we were amazed the way the distal vessel looked. As you can see, it is positively remodeled and no further stenosis. And if you compare the post DCB, which is on this panel, and compared to what it was 12 months later, you see the positive remodeling of the vessel. So these are the classic indications for DCB. The third case is a chap who presented with inferior myocardial infarction with no previous cardiac history, had a hypertension and hyperlipidemia as a risk factor, including smoking. So he had an angiogram of the left system, which shows a moderate disease in the LAD, but none of them appeared flow limiting. But the culprit was the right coronary artery, which was ectatic, filled with thrombus. And you could also see the RV branch is blocked here, some late filling. So here you'll see the epicranial, you'll appreciate the ectasia more here. So before the crux, there's a big ectasia and a lot of thrombus and very poor distal perfusion. So obviously we wired the vessel, ballooned the ostium of the side branch, and we used a magic touch in the side branch. And then we wanted to focus on the distal vessel. There was a lot of mismatch in terms of size. We all agree that stent's not ideal here. So we ballooned with a non-compliant balloon, and we used a magic touch distally and also in the crux. This was the final result, where there was a TIMI3 flow in the distal vessel, a lot of spasm. Patient was pain-free. His ECG got better. We gave him a GP2B3 inhibitor for 12 hours. And he had some moderate disease in the LAD. So we came back for a pressure wire assessment of the LAD at 3 months. And when we took the angiogram of the RCA, you could see it's nicely healed up, TIMI3 flow, and you'll appreciate this in the epicranial view. The ectasia is still there, maybe some thrombus is still present, but the whole vessel is opened up now, TIMI3 flow, and patient's doing well. And the last case is of a 65-year-old man who presented with a lateral myocardial infarction in the background of usual risk factor, smoker, and hypertension. The angiogram shows occlusion of the diagonal. You could appreciate here, there's a bit of dye hang up here, and it's a flush occlusion, so right from the ostium. And you'll appreciate in the spider view, that's the occlusion of the diagonal. LAD is free of any significant disease. So obviously we wired both LAD and the diagonal. We did a POBA with a 2 millimeter balloon, and then we used a scoring balloon in the ostium. And obviously here, putting a stent means you'll have to convert this into a proper bifurcation stenting, and hence we opted to use a DCB. So this is post-POBA. We are happy with the results. So we used a long magic touch, 2.5 by 25, and we had a final result like this. Patient was asymptomatic by this stage with resolution of ECG changes. And he came back for a follow-up angiogram at 6 months. You could see the flow in the diagonal is excellent. There may be some recall in the ostium. We did a pressure wire of the diagonal and LAD, both were negative, and hence we didn't do any further intervention. So in summary, my colleagues, Magic Touch appears a promising technology. One of the best thing about the device is it's excellent for deliverability, especially for distal tortuous lesions. Clinical outcome from our population has already been published in CCI last year, and we're going to be publishing a long-term data hopefully in the next few weeks. Appears low with low rates of hard endpoints and acceptable rates of MACE and TLR. So results are encouraging, although we need long-term data and maybe data comparing the paclitaxel, which is currently ongoing. Thank you very much for your attention, and I'll be happy to take questions.
Dr. Sandeep, great cases, and
Thanks,
Magic Touch appears to be very promising technology, and especially in diffuse disease with small vessels, side branches, we have had all of us have had very good results, and it appears to the policy of or strategy of leaving nothing behind is fully endorsed by this technology. So before we go to Dr. Pratap's talk,
Luca wanted to have, one question to Sandeep. Actually, there are a lot of people are actually asking one question. When you use a stent, the drug delivery will be up to 90 days or 30 days minimum. But in the drug deliveries of 60 seconds or 70 seconds, how it can remain making the vessel patent for long?
That's a very good point you asked me. So look, if you ask me whether DCBs are better than stents, we cannot answer that yet because we're not comparing all lesions. Only in small vessels we have data, maybe restenotic lesions. But that 60 seconds is enough for the drug to be transferred into the vessel wall, and we have seen a lot of animal models. And once it's there, it's only in the vessel wall for less than 28 days. After then, it's gone. Whereas stent, it stays longer, which is why we can get away by using DAPT only for, in fact, as low as 2 weeks. I've used only for 2 weeks in patients undergoing cancer surgery, and we've had no problems.
The question is it sufficient?
Well, I can understand because stents elute, which is why it's called drug-eluting stents, whereas this is a drug-coated balloon, because it doesn't elute over time. It only elutes for 60 seconds.
So this makes people apprehensive. But I have an excellent experience with the Magic Touch, and I used a lot of Magic Touch, and my results are very good. So that is.
No, I think, look, as I said, if you ask me for a left main proximal LAD, I would not use DCB on its own because there is no data to use it. But for small vessel long lesions, I think they have got some excellent data, and it makes sense to use it.
Right. Yeah, Pratap, ideally you have to keep it for 60 seconds, but if the patient can tolerate, you can keep it for 90 seconds.
Yes,
there are studies we usually keep minimum 70 to 80 seconds, no doubt about it. But I'm just telling, the question arises by all the people who are opposing the drug-eluting balloon. This actually question for the audience. That's what I'm telling.
No, it's of immense value in intent context because of the diffuse coronary artery disease with diabetes.
Very.
So the proximal you did a port stenting, and mid and distal and branch vessels you do a drug-eluting balloon. The vasomotion is preserved, no risk of stent thrombosis, and good for high bleeding risk patients, and very positive remodeling also, as you have demonstrated. Excellent work.
Samir,
Pratap, some people do argue that the first or initial burst of drug which goes into the vessel wall is most important for inhibiting the intimal proliferation, and that is why the drug-coated balloons work. And some drug with this nanolute technology does last in the media and adventitia up to 14 days, even when there is only one burst of drug delivered by the balloon.